child in the paediatric emergency department. So what I'm covering is I'm basically just going to be covering alcohol. So for especially for guys who, so mainly I'm looking at sort of the pediatricians in this group who may not be as familiar with alcohol intoxication as certainly us people who do a lot more adult medicine. So we'll talk a little bit about the pharmacology, sort of considerations you need to think of, complications, the acute management, and I'm going to spend a little bit of time talking about aggressive patients, and then we'll do a little bit on alcohol dependence. Now, why am I talking about this? So a bit shameless self-promotion. So whilst I was at Leicester, Damon kindly invited me to write an article, so which is a practical approach to the intoxicated child, which does it basically is like an overview of all intoxication, so like all poisoned, with a bit of a focus on alcohol, which is that we'll focus on. But if you want to have a read of it, because you want to know more about children, younger children and toddlers who ingest alcohol and general sort of management, please have a little read, and that will hopefully will cover most of the points that you want to look at. So why am I talking about it? Why is it important? So as you can see, so in Europe, the UK has got the highest average alcohol consumption, certainly, and it counts for roughly about 15% of all ED attendances, including adults. So it's a relatively biggish problem. There is an increasing incidence of binge drinking, and mainly among girls. So you may often find, so if you haven't already, you probably at some point in your PTD time will come across someone who's come in very intoxicated and is being brought in by ambulance. So what happens, or what does alcohol do? So it's a selective CNS depressant. So when it's ingested, it's rapidly absorbed. So even if you've been vomiting, it still is absorbed into the blood, and your peak concentration happens roughly around 90 minutes. Now, it's eliminated by something called zero order pharmacokinetics, which basically means is that it's eliminated at a set rate, which is important when we'll come to about some of the treatments that you can use, and it's mainly excreted in the urine at a rate of 0.01 to 0.2% an hour. And the chart on the right shows, so with increasing alcohol concentrations, the more symptoms you get. So at lower concentrations, you get decrease in inhibition, diminished fine motor coordination, slightly higher impaired judgment coordination, and then high levels difficulty gait and balancing, and then to lethargy, difficult sitting up stroke without assistance, to coma, and respiratory depression, which I'm sure most of us have been at the, given how available alcohol is, at the sort of lower ends, but hopefully not a lot of us have been at the higher ends, maybe when we're at medical school, but I won't say anything. So considerations for children. Children have body surface water have a higher proportion and a higher proportion of surface area, and so they are more likely to absorb things from the skin and lose heat. Airway wise, airways are smaller and more likely and can be more likely to obstruct. So especially in younger children, so certainly maybe not in teenagers, but renal and hepatic function is more impaired, and that the glycogen stores are a lot less, so you're more likely to become hypoglycemic. So things that you consider when you're presented with these children to consider is that have they ingested, so are they unconscious just because of alcohol, or have they ingested something else? So asking about who were they with, what circumstances were they found in, was there other drug or alcohol paraphernalia around, but being aware that the patient may be an unreliable witness, and the people who were with may also be drunk and may also be unreliable, wants to conceal that they've been doing drug taking. The other considerations, obviously, so certainly we talk about adolescents, and most people who present to PTD would be under the age of 16. At Leicester, it was changed, so it was people, we saw quite a few of these because we were seeing people, because of COVID, people under the age of 18. But that's below the legal age limit that you can drink. So think about where they got alcohol from, where parents are aware of this. Again, what circumstances were they drinking, etc. Because there's obviously sort of safeguarding considerations you need to consider. Having said that, adolescents are more likely to be experimenting and doing risk-taking behaviour just because of the age group they're in, and I'm sure we've all been teenagers before and participated in risk-taking experimental behaviour before. So certainly, if this is their first presentation, it might just be a one-off, and certainly exploring that is important. And then the other thing certainly to think about is, when you're seeing these patients, is have they incurred an injury when they've been found? So have they got any evidence they've got a head injury, or they've fallen down a flight of stairs, or or got a long bone injury, or worst case scenarios, other scenarios where they've got an intrathoracic or pelvic or intra-abdominal injury, which makes explain why they are semi-conscious. So certainly doing a full AT assessment and looking out for those sort of signs is important, and progressing onto relevant imaging should you find evidence of injury. And then the main complications you get from alcohol intoxication is, you get hypoglycemic, you may be hypovolemic, hypothermia, CNS impairment, and respiratory depression. So talking about the agitated patient, so the main reason I'm talking about this is that certainly where I was in Leicester, we had a number of cases where we had aggressive and violent patients come to the ED, and certainly us people who are emergency physicians who see adults have certainly come across dealing with the acutely agitated patient a lot, but it doesn't happen so much in pediatrics. And certainly up until this year, most of the pediatric ED consultants at Leicester had never chemically sedated a patient because they were so agitated. But we had 3 cases, and there wasn't actually a rapid tranquilization protocol. So a lot of the drugs and sedations were a bit unfamiliar, and certainly the de-escalation techniques in dealing with these patients were very unfamiliar to the nurses. So first thing to say is you need to consider age in terms of whether you are going to chemically restrain a patient. So assessing, if they're over 16, you can assess their mental capacity, and assessing mental capacity is 2 elements. So do they have an impairment of consciousness, and if they have impairment of consciousness, are they able to interpret, understand, retain, weigh up, and communicate their decision to you. That's not always as can be as clear cut as that. And if they're below 16, they can consent to treatment. So that's get a competence if you believe they have the capacity to do so, but they can't refuse treatment. And certainly, I think my take-home message from when I've been dealing with these children in the PSD is seek help. So this is the kind of thing I would, if it was at night, I would be waking up my on-call consultant, or if I am the consultant, where I might actually speak to one of my colleagues and having to think about what I would speak to about advice in terms of whether I can actually restrain this patient or not. Before you get to that, right, there's some things you can do. So de-escalation techniques. So this guideline on the right is taken from Glasgow, but there's also RChem. There's also a very good RChem guideline about managing the acutely disturbed behaviour patient. So again, that's something else that if you're interested in, I have a little read of because it's very useful. But it talks about de-escalating techniques. So I often find these patients, by the time I come to them, they're being restrained by 2 or 3 big people. And what I try and do is try and put myself in their shoes. And certainly when people have impaired judgment, due to alcohol intoxication, for example, they kind of go into an innate behavior. So if you've got 4 big blokes pinning you down, you're probably going to be kicking and screaming and being violent because you're scared, you don't understand what's going on. So try and break down those barriers. Often, especially I find in intoxicated patients, actually de-escalates the situation more times than not. So in a safe way, and you have to be very conscious about how you feel safe in the area you're in, about taking off the restraints, understanding what, sort of trying to be calm, move into a side room, try and be non-threatening, use good non-verbal communication, and trying to de-escalate the situation that way. However, often, certainly if physical restraints are in place, that the horse might have bolted, and actually all the de-escalation techniques you can use may not work. So certainly using physical restraints to facilitate the initial management needs to be proportional, justifiable, and minimal, and that's really important. But certainly, if someone's been physically restrained, I had a very low threshold to chemically restrain them, and that's for their safety. Because if you ever look at a blood gas with someone who's been held down, certainly more than 15-20 minutes, their lactates probably into double figures, and they're probably acidotic. And certainly a lot of the deaths that happen in custody is a lot of it would be due to being physically restrained, trying to fight against it, and then getting yourself into trouble that way. Now, most people, so there's, in a lot of hospitals, certainly the adult side, there will be a chemical restraint guideline. So most people most of the guidelines would have some sort of benzodiazepine as their first line agent. You can give that IM, IV, or oral. Certainly in children, that's probably my first line agent, especially in sort of drug-induced delirium, because it's quite good in sort of counteracting the excitational part of whatever drug they have been taken. But also, I found certainly in adults antipsychotics very useful. So certainly one of my personal favourites would be droperidol. I've used promethazine before. What's important to remember with children, though, is that children are more susceptible to getting the extrapyramidal side effects of these drugs. Certainly, the typical antipsychotics, so haloperidol, promethazine, and droperidol. So most of them are antidopaminergic agents, and that they may get dystonias. And so certainly being more prepared if you are going to use those drugs to counteract those side effects. I have found actually a lot of pediatric physicians very reluctant to use these sort of antipsychotics, and often they'll use benzodiazepines. If you're unsure, I found CAMS consultants quite helpful in terms of what they would recommend using. So I've had a broad range of things said to me, but usually it would be along with something like haloperidol, something that's used quite regularly. And then once you've chemically sedated them, or so the other thing is thinking about route. So obviously oral would be your first line. So say if you manage to de-escalate the situation somewhat, then giving an oral tablet is probably it was the first line agent. If you've got physical restraints in situ, then making a judgment whether it's safe enough to get IV access. Sometimes it's probably not. And then using IM. The problem with IM is obviously it's easier to administer, but more unpredictable about when the effects will hit compared to IV. And then once you've chemically sedated and you've got control of the situation, then you're looking at supportive hospital management. So looking at if they've taken other evidence, they've taken other substances, treating any hypervolemia, hypothermia, and any sort of metabolic disturbance. So looking at things, certainly I would probably look at toxabase to see if there's any sort of evidence. So taking other drugs, and certainly things like CKs, looking at electrolytes and blood gases. In that situation, that's what we'll be doing to make sure there's nothing else going on. So moving on. So acute management. So going back to how alcohol is eliminated, because alcohol is eliminated at a steady rate, giving someone IV fluids to wash out the alcohol, there's actually no evidence to say that works. So you should only really give IV fluids if you've got evidence they're in shock or hypervolemia. So tachycardic, dry mucous membranes, there's been a lot of diffuse vomiting, etc. But the routine use of IV fluids is not recommended. But these patients often will regain consciousness, or after a couple of hours of observation will wake themselves up and usually be able to be discharged from the department. But they need to be in a close observation, so they need to be in a sort of high visible area in your department, and they need to have regular obs, so looking out for evidence of airway depression, hyperglycemia monitoring, hypovolemia, so blood pressure monitoring, heart rate, etc. With respiratory depression, certainly the concern would be airway and the aspiration risk. So alcohol blunts, reduces your gastric emptying and reduces your airway protective reflexes. So these patients should be managed certainly when you see patients being treated in these drunk tanks, so when these vans pick up people they've done obtunded, they've always been nursed on the side. And a lot of deaths from alcohol usually result from airway obstruction due to respiratory depression. If certainly when I see these patients who are very obtunded, what I tend to do is actually put end-tidal CO2 monitoring on them to make sure that they are breathing regularly. And if any sign of not having a GAD reflex and respiratory depression, and apneas, then I would have serious consideration about whether these patients need airway support, i.e. speaking to my anaesthetic colleagues and think about intubation and ventilation. Make sure they you treat any that's meant to say hypothermia, not hypothermia, but treat with blankets to keep them warm, regular blood glucose monitoring. And then there's a rare complication of alcohol called Alkaloid Ketoacidosis, which is described in the picture on the left. So basically what happens is that this is more for chronic drinkers, so you basically have increased alcohol intake and you don't take as much food, so you get glycogen depletion. And then when you stop taking alcohol, because you get depletion of NAD, you basically get inhibits glyconeogenesis, and you get decreased insulin production. So you will get if you check people's ketones, or you do a blood gas on these people, what you might find is that they have a normal glucose level slightly low, but their ketones are quite high with a metabolic acidosis, and we often will have features of nausea and vomiting. So certainly if patients come in, they're obtunded, and there's been a history of lots of vomiting, I would do a blood gas to see if there's any evidence of alkaloid ketoacidosis. And the main way you treat it is actually fluid resuscitation. So normally you can use normal saline or 5% dextrose. The warning with 5% dextrose is that you need to give them these patients thiamine replacement, because you can precipitate a Wernicke's encephalopathy if you give someone glucose who's stopped drinking alcohol and chronic drinkers. And then a little bit about alcohol dependence. Again, rare, but certainly I've come across it once or twice in teenagers. So certainly you need to, these are safeguarding concerns. So people who require admission, so certainly if I think someone's coming with multiple tendencies with alcohol intoxication would require some sort of safeguarding referral, spoken to secondary services. That if I would have a low threshold to admit these patients, or looking at NICE guidelines, admission criteria for patients would be if they are undergoing acute alcohol withdrawal. So usually symptoms you would get would be shaking, tremors, so delirium tremens, so shaking, tremors, sweating, anxious, and the main treatment for alcohol withdrawal is some sort of benzodiazepine and thiamine replacement. And then you can use, it's recommended to use a common assessment framework and referral to specialist treatment if, so i.e. CAMS, if there's signs of moderate severe dependence using the framework, or risk factors of self-harm. So that's recent accident or injury, regular attendance to GMU clinics, involvement with crime or antisocial behaviour, school absences, or looked after children or patients known to social services. So certainly in those circumstances, I'd be sort of looking to get these patients referred in for assessment and acute management into services. So summarising all that, so essentially when you see these patients, especially obtunded ones, they need to be observed in the ED, certainly in a high visibility area with regular monitoring. Don't get pulled into the nurses saying, oh, it's just another drunk so-and-so, and leave them around the corner, because that's where you might be running into complications. Being aware of the complications, so that's respiratory depression, hypothermia, hypoglycemia. Don't give these patients fluids routinely, and just remember about safeguarding issues, and if there's signs of dependence, then either offering inpatient withdrawal therapy or referral to CAMS and alcohol services. And that's it. Do we have any questions?
Thanks, Dan. It's Ash. I'm pretty used to running a mental checklist of significant other potential diagnoses with lots of our general medical presentations and things that I just don't want to miss and get caught out by. Do you have a list in your head for the child that on the face of it is alcohol intoxicated, just to make sure you're not going to get caught out?
I would certainly say it's really important to take a detailed history. So before the ambulance guys leave, if you are, or certainly getting your triage nurses to ask those questions about where were they found, what is there any history of what was happening beforehand, was there evidence of drug paraphernalia, has the child been searched to see, like, they got that evidence of drug paraphernalia. And then when you're examining them, looking for, so remembering that, remembering your toxidromes. So often, so different toxidromes, you'll get different, obviously symptoms, but things that people commonly forget to look at would be like Are they sweating? Have they got dry skin? What are their pupils doing? Are they hyperthermic or hypothermic? And if they've got evidence that they've got big dilated pupils or pinpoint pupils, they're diaphoretic, they've got flushed skin, have they defecated themselves? Are they angry, really aggressive, tachycardic? Those sort of when you're doing your initial assessment, they're the sort of things I'm thinking about, looking for evidence that have they taken anything else. And I think, or the other big thing would be metabolic problems. So remember, you don't forget your DKAs and your hypoglycemic patients classically coming in, aggressive and obtunded, and actually they are diabetic and they've got hypoglycemia. So those sort of things, and then trauma. So have the back of the mind is that have they got really drunk and got into a fight and then been smashed in the face without you knowing. So looking for the signs of focal neurological deficit, signs of head injury, and if you do get those signs, then considering neuroimaging, and that's probably the only time I would think about neuroimaging these patients. I hope that answers your question.
Yeah, thanks. That's really useful.
Any other questions?
Dan, thanks very much, Zanika. I was just going to say, I think you mentioned about rapid tranquilization, and acute behavioral disturbance. I think the problem with being under 16 is that you can't do the mental health assessment technically, and also some of the drugs that are used in the adult department are not actually licensed for under 16s. No. And so we would very much go on the advice of the CAMS consultant, who has actually more experience of the drugs that they use. And I know on the ward at the moment, we've got various issues going on with, various cocktails of things like quetiapine, risperidone, lorazepams, all kinds of things. And I think the one thing I've just learned recently is that the CAMS consultants also, actually, they are essentially talking therapies. And they are not used to dealing with acute behavioral disturbance on a ward. They're general CAMS consultants. So I think this group does fall into a bit of a grey area where the adult doctors have more experience of the drugs that you guys use at adults. Pediatrics doesn't, and they're not licensed. And even the CAMS teams actually sometimes don't have experience. So, and they're not licensed drugs. I think that's where it's quite complex. So we tried to.
So what I wrote in my article was basically, I basically said there's no, unless you have a guideline. So guidelines are helpful, but like I said, is that so I wasn't aware particularly that when I started my PEM year that actually a lot of these, so it was more in the context of antiemetics, actually you're more likely to get the extrapyramidal side effects. And actually we had a very agitated patients in the ICU, and even then when they would rather intubate someone than rather than use a lot of these antipsychotic drugs without guidelines. So I think it's just more that I was just giving a general overview. What I said is that use drugs that you're familiar with and you know how to counteract the side effects. So a lot of people, certainly pediatricians, are familiar with benzodiazepines. Hence why that's probably what, if you can't get hold of a CAMS consultant, you're in a sticky situation, patient safety is at risk. That's something I would use. I personally think it's a bit of a fashionable thing at the moment to use ketamine. And again, it's in the RChem guideline. Now, my personal view on ketamine is that I don't understand why I can understand from an airway point of view and a sort of safety point of view and getting someone quiet, but you get yourself in a hole because obviously the re-emergence phenomena. So giving an agitated patient a drug that might make them agitated even more seems a bit counterintuitive to me. I've used other things. So I've used in Australia when we not necessarily with children, but there's a big methamphetamine problem, you either have to give them lots of benzodiazepines or actually you have to give them a GA. So these are all sort of things you're considering, but the other point I was trying to make is that you shouldn't ideally try and make these decisions in isolation. Phone a friend, get advice. If you're not able to get hold of the specialist, i.e. like a CAMS consultant, certainly speaking to another consultant and getting a consensus on what to do in terms of trying to maintain safety, and then go from there. I hope that sort of answers the question as well.
No, that's great. Thank you.
I think the other reason why I wanted to talk about it was actually because of the experience I had in Leicester, where I was actually, when I was in the department, you know, there's some very experienced PZD consultants who work there who this is completely alien to them, and even in their careers they've never done it, and that's working in a very busy PZD. So it is quite rare to get that far. That happened a couple of times recently. Lovely. Any other questions or thoughts or comments? A couple of minutes.
Dan, I just wanted to also just go back to say, I'm really glad you brought up the heads assessment. I think I'm glad that it's actually, there's more awareness of that now. And there's actually a whole day course you can do about us doing the heads assessment properly. But I think the initial screening. So I think just thinking about ages, I think anyone who is Fraser competent, you know, over 12, is mature enough, should really be seen on their own with parental consent if possible. And a lot of the teenagers won't talk to anybody about their issues at home or with school when they have an adult with them. So I would encourage, and I think that's good practice. I mean, I know even from the RChem, there's been guidelines and suggestions about how we approach these young people, and it's fine to actually speak to them on their own. So you just start with saying, you know, young people have told us that they like to speak to people and practitioners on their own. We can keep things confidential if required. And, you know, often the parents will leave at that time. So I think something about engaging with that young person in a way that you remember they may be 5'10" or 6 foot, but actually their psychology is of a 13, 14-year-old. So don't forget that even if they're big physically, but psychologically, it's quite a difference. Yeah. And then also within this group, it's such a variable group, because you might have a very protected 12, 13-year-old or a very worldly wise 13-year-old who's been exposed to a lot because of the home environment. So I think one of the challenges is, as you say, is the psychology of this group is very variable. And we just need to be mindful of, actually, they are still children. And I do agree with you that I think the difference between adults and pediatrics, I imagine, is that with pediatric population, you can actually have a much greater influence on their trajectory. So if we can get these kids, you know, and often it comes from, you know, dysfunctional families, you know, drug abusers at home, parents, etc. So family dynamics are not good. And the you know, the children are just kind of a byproduct of that environment. So I think the etiologies of this is often different for children compared to adults. And I think what we do with them in ED can really significantly impact on their trajectory of their lives and their life success. So I think it's really great that we do engage with these young people. And I've just put some references on from the Royal College about listening to the voice of the child and really hearing what they're saying. It is about alcohol and drug, obviously, because that's a manifestation of their environment, but getting to the root of the problem and why they're actually doing it is also trying to be one of the practitioners in that we can try and address those issues with them in PZD as well. So I agree with you that it's definitely a multidisciplinary approach to the children. We deal with them in PZD, but actually behind that, it's like the iceberg, isn't it? There's loads of things that need to be addressed behind it. You know, signposting, prevention, etc. as well. So well done for raising that.
Yeah, I think they're really excellent points. I think the other thing, sort of coming from a sort of like EAD background, is a lot of these patients, when you, but some of the reason why they're difficult is because you've got, in the back of the mind, you've got, an ED full of bronchiolitis, and you've got lots of people waiting, and these patients are going to take time, but that's exactly what we need, is a little bit of time. And often actually you can manage them quite well when you spend a little bit of time. So just having that sort of situational awareness and being able to do that, will, you probably hopefully you'll get better outcomes. Ash, very quickly, you had your hand raised.
Yeah, sorry, I just wanted to flag that so Sophie in the chat has just signposted the Heads app as well, which is a fantastic resource. And ARCHEM mandates that we should be doing this on everyone over 12. I think at last audit it was 10% of kids over 12 that are getting this done. I think it's even more important in the child that's not presenting with an overt mental health or sort of psychosocial problem that we're doing it. And we should know what to do when we get an answer as well. So if they're saying they've got a drugs problem, we should know what to do about that. And the Heads app is a really great resource to start with if you're not sure where to signpost people to.
Perfect, that's great. I wasn't aware of that, but that's excellent. So thanks for that, Sophie and Ash.
Just one more thing, Dan. Thanks, Sophie, for that. I was going to say, I know I don't know if we've got anybody from Watford here, but they've introduced a casualty card for 13 to 17-year-olds, which actually include emotional observations. So quite right, Ash, actually, it's not just about the ones that present acutely with, disturbance of their behavior, but actually it's asking everybody, because unless you ask, a 13-year-old how they're feeling, they're not going to tell you. So as well as taking clinical history, it's about taking an emotional history as well, and introducing emotional observations into these children's kind of like charts, really, so that we are aware that they, we should be taking a holistic approach to pediatric care. It is all linked, physical and mental health, and we know there's a mushroom of mental health issues. So yeah, just an awareness of that is really useful.
I was going to say, it sounds like a quip or someone waiting to happen in other places. So there you go. So thanks for all your input, guys. I hope you guys enjoyed the talks and found them useful. There's just a couple of references. So obviously I've talked about the sort of paper article I've recently done. On ARCHEM Learning, if you've got access to it, there's the thing called, I think it's not the Lost Tribe actually, it's called the Forgotten Tribe. You may be able to get access if you haven't got access to ARCHEM Learning, but it is just an article talking about the Heads assessment, and there's also learning about if you want to do a bit more reading about alcohol intoxication and alkaloid ketoacidosis. I talked about the Royal Children's Hospital Melbourne stroke guidelines, and on the chat as well there's some other guidelines from NICE about stroke. And then there's the ARCHEM guidelines on rapid tranquilization and acute behavioral disturbance management. So it's great. So thanks everyone for attending. I think, I'm not sure the exact date for the next meeting, but I believe it probably is, I'm going to look at my calendar, would be due to be either it's probably the 21st of September. But certainly we'll get some information out to you guys as soon as we get a program together and talks. So thank you. Thanks everyone.
Thank you.